Thank you, everybody. Welcome to my lecture called Heterogeneity ARDS is Redundant. I have no conflicts of interest. So let's start with a definition of a syndrome, because don't forget the S in ARDS is syndrome. It's a set of medical signs and symptoms which are correlated with each other and often associated with a particular disease or disorder. So in other words, as a syndrome, it's no surprise that ARDS has got a lot of heterogeneity. And when symptom is paired with different cause, it becomes a disease. And I've always wanted to do this. I hate, when people give Merriam-Webster. This is from Wikipedia, and with special thanks to Gareth Garrison, who some of you may remember had a lecture once with Wikipedia quotes. So to some extent, ARDS is herding cats, because it is not really any one thing, as it turns out, and it's not so simple as we've learned through the years. And the reason this is worth considering from my perspective is that as a trialist, most of our ARDS trials have been negative. This is almost 10 years ago now, but it's kind of a forest plot of a lot of famous ARDS trials. Here you can see the ARMA trial, 6 versus 12, if you will, from 2000. And here's ProSeva, the prone trial, but most everything else is no good, or in this case, Oscillate, the Canadian oscillator trial, harm. And if you want to update it since then, we've had we've had additional number of negative trials like SAILS, ROSE, which was our neuromuscular blockade, ART, which caused harm actually with high PEEP, EPIVENT, which is esophageal balloon, the LIVE trial, which I'll comment more later. EOLIA was a negative trial for ECMO, stopped early for futility, but when you start playing Bayesian games and things like that, and you look at patients that crossed over, you consider it positive, but technically it was stopped early for futility. DEXA ARDS really the only positive trial, I think, in recent years since ProSeva, and steroids. So yes, I'm going to go there. I'll wait for that. And I know Haley had a article with Jackson years ago, and on HTE, heterogeneity treatment effect. And that's when you go backwards in time and say, well, no wonder this stuff didn't work, because your treatment didn't have an equal impact on all comers. And so the converse, if you will, the prospective component of HTE is to try to subphenotype and try to address things on the proactive side, and then enroll selectively to try to impact on the people you think you're going to help. So that's really the undergirding theme of this lecture. Okay, so first let's start with the Berlin definition, and really a lot of people are even starting to get tired of using the term ARDS, recognizing our consternation and confusion. It's really a subset of acute hypoxemic respiratory failure with bilateral, here I've underlined it, opacities. And what's going on in those lungs is often not known, and I'll comment on that as well. The Berlin definition was intended to accommodate the adoption of pulmonary arterial catheter. Non-invasive, as you can see here, the fine print was included, and probably the next iteration of Berlin coming out will have heated high flow. But I think the point of the matter is acute hypoxemic respiratory failure, not due to heart failure, it's bilateral, not due to these other kinds of things, atelectasis, collapse, effusions, nodules, is ARDS. And we start to think about ARDS, we think about risk factors, and there are a number of those. You can kind of sort those out into pulmonary ARDS and extrapulmonary ARDS, direct lung injury or endothelial injury, the big four being pneumonia, aspiration, sepsis, and polytrauma. But just from the get-go, the heterogeneity number one is there's a lot of different causes, and I would challenge you to think about, you've probably seen fat emboli, for example, or maybe drug overdose, pancreatitis, TRALI. Is that the same ARDS as your septic ARDS? And we don't really know, of course, because if you have TRALI and get better in a day, we're not doing a biopsy or an autopsy. So is that the same thing? So there's a lot of risk factors, not any one thing, and a lot of all roads lead to Rome when it comes to presenting with the syndrome of ARDS. Now, just because you develop a risk factor doesn't mean you're going to get the disease, or the condition, I should say, the syndrome. And this is the LIP score. Pauline Park participated in this with Oki Gajic. And even if you have a lot of LIPS points, you can see some of the points you get for sepsis or aspiration or pneumonia or alcohol or obesity, et cetera, et cetera. Even if you're at a LIPS 8, really a 35% chance of developing ARDS. So there really is also heterogeneity in terms of development after you develop a clinical insult, because only a percentage. So not only is there an array of insults with heterogeneity, there's really no guarantee, even with multiple risk factors, you're going to go on and develop a syndrome. Next aspect to think about is, do we know it? We see it. This is Mike Schoeding's work from a few years ago, just saying that, do we know it? We see it? Well, everyone thinks they do, but they may not be in agreement with their colleague. And this showed, particularly with regard to the chest X-ray interpretation of pneumonia versus ARDS, a fairly unimpressive kappa for agreement between our expert clinicians here at the University of Michigan. So do we know it when we see it? Well, gee, there's heterogeneity in terms of clinical diagnosis. Because if I say it is and want to enroll someone, you say it isn't and don't, or I say it is, I'm going to treat someone a certain way, and you say it isn't, you're going to treat someone a different way, then we got maybe a problem. Now you can ramp it up. There's something called the rail score, just for the sake of completion, to try to be a little more exacting in your analysis of the chest X-ray. More on this later when I talk to you about the live trial, but you can increase that inter-observer agreement when you are rigorous. But I mean, who actually, I don't know very many people whip out the rail score at the bedside, but perhaps we should. You also have to think about imitators ARDS, just because you present with that bilateral opacities, acute hypoxemic respiratory failure, not due to lumbar collapse or heart failure, et cetera, pleural effusion. How do you know it's not, say, for example, as we often will see, alveolar hemorrhage? And here's a list from a review a few years ago, talking about imitators of ARDS. Again, I think the big one we see is hemorrhage, but there's other things too, perhaps less common. BOOP, acute eosinophilic pneumonia, which if you don't bronch me, you'll never find it. Seen that, drug-induced, et cetera. So there's certainly heterogeneity there as well. So ARDS is under-recognized. So not only you can't agree on it, those that have it often go undiagnosed. And this is a overview from 2 years ago, 3 years ago now, in intensive care medicine, to just comment on the fact that going through the various criteria, how you can have some ambiguity. In fact, that's been shown. This was lung-safe data from, it looks like I forgot the reference here. It's showing that ARDS doesn't not recognize only 60% of the time, and obviously recognition goes up per Berlin category. More severe hypoxemic you are, but on balance 60%. So that's a lot of people unrecognized. And the other thing worth commenting on is the notion of lack of meeting criteria after just 24 hours. Okay, so remember that Trally patient, for example. You're gonna want to enroll a Trally patient in a fancy clinical trial. It would be increase the noise if they're going to get better on their own anyway. And in fact, this was lung-safe data from originally in JAMA in 2016, but sort of demonstrating that even Berlin severe can have resolution at 24 hours. So on balance, within 24 hours, 24% of patients meeting ARDS criteria are resolved. Now, when you think about what we did in PETAL, the whole wrinkle of PETAL is let's get these people early. We'll go down to ER, EC3, what have you, and enroll. And then, in hindsight, this analysis coming out after PETAL was formed, but perhaps being misguided, right? Because if you identify people early, enroll people who are going to get better anyway, then you're going to dilute the signal of anything you might be trying to study. So there's heterogeneity of syndrome duration as well. And this just shows you at ARDSNet trials. This is also true. We were part of ARDSNet 1, SKIP 2, we're part of PETAL, but this is the original ARDSNet 1 and 2 trials, and patients got better. You can graph it out. This is the original ARDSNet 1 trials, and this problem got worse over time, actually, when you look at the patients who got rapidly improving ARDS, and this was the positive trial. In fact, was fluids and catheter, so it really didn't comment on improving ARDS outcome. Alveoli was a negative trial, but alta, cells, beta agonists, these kinds of things that were studied here with ARDSNet 2 that we did not participate in, increasingly becomes a problem. So heterogeneity, a syndrome of duration, and that can certainly serve as significant to confound. Now, in PETAL, we enrolled in the ED, but these were patients at risk for ARDS. But Rose did make an attempt to enroll persistent ARDS. It was after 24 hours. It was a PDF under 150 with a PEEP of 8. So at least come mid-PETAL, despite the fact we had this ER slant, we were rolling extant ARDS and persistent ARDS. So what you should see here, with the syndrome is diffuse alveolar damage. So it does suggest a disease, if you will, a link between these findings, these clot in the lung, hyaline membranes, if you will, and rich PMN infiltrates. And by the way, you can be leukopenic and still develop ARDS, right, Dick? It harkens back to a paper he had in 40 years ago now. But the point is that we don't get tissue except that if you're getting better or dead, and that's obviously a selection bias. But when you look at autopsy specimens and sort by Berlin, really only seeing DAD a certain percentage of time. Sure, the longer it persists, the more likely you see ARDS. The more severe by Berlin, the more likely you see, I'm sorry, DAD, I should say. But the main confound here is pneumonia. Here, that's in black. The main thing you see when you don't see a DAD is pneumonia. More on that later. But the point of the matter is, again, if we're thinking as a trialist, you want to impact on DAD because that's what you're going to do. You're going to give something that's going to have epithelium, and you're going to give something that's going to decrease endothelial leak. And you've got a bunch of people that don't have what you think they have, and you don't really know because they're alive and you're not biopsying them. Then you don't know. Now, even if you biopsy people, the same problem holds. This is old Papazian data, and this is this whole CMV thing that got us started with the GRAIL trial. CMV positive patients, is it a confound or is it disease worsening entity? But the point of the matter is when you look at biopsies, and again, you don't biopsy people who are getting better, so selection bias here. But when you take people at 7 or 10 days and do an open lung biopsy, you're going to see a lot of people who don't have DAD. Here, if you look over 83 patients with no DAD and 35, DAD and 48, most of these patients had pneumonia at the onset, ARDS, more than that, just a second, but you don't see ARDS all the time. This is a more recent sampling from PLOS One, and so the same thing holds. There's just heterogeneity histopathology. In other words, you may meet the criteria for the syndrome with acute hypoxemic respiratory failure. You don't know what's going on in those lungs. If you make them better, chances are you're never going to know because you're not going to get bats, and hopefully they live. You'll just never know. But as a trialist, if you think about it, what are you trying to treat? What are you trying to make better? What's your therapeutic target if there's such heterogeneity, and does that serve as a confound for trials? So this notion of persistent ARDS, does it have legs? Well, I commented in the Rose trial, we did try to enroll only that. Again, this is that same intensive care medicine article in 2018. And clearly, if you look over here to the right, severe persistent ARDS is a target for improvement because you have over 50% mortality. So certainly you've got a population, if you will, that you can have an impact on, you think. And if it looks at risk factors for persistent ARDS, perhaps it's not surprising that sicker people in shock or pneumonia are more likely to develop persistent ARDS. And this I'll harken back to the APS consortium at the end of the talk, but this is where the rub is, that all these things overlap: shock, septic shock, a main risk factor, pneumonia being the main cause of that risk factor, and then having this syndrome. So it's a big issue of overlap here, but those are risk factors for persistent ARDS. So is it value? Is there heterogeneity by oxygenation that serves as a meaningful subgroup that we should study and only enroll them? Well, as I said, the mortality is higher, so it seems like a good opportunity. And there's been some advocacy on that part. If you look at if you're trying to split it down the middle of a PDEF of 150, that's Berlin moderate. It's the more severe half of the Berlin moderate, right? With the PDEF under 200 constituting moderate, under 100 being severe. So you're saying, let's split it down the middle, called 150. And if you look at CAT scan information, it does seem to correspond with the amount of gas in the lung that's recruitable. But when you, at least the time it's been attempted, now Rose was a negative trial. And when you go back to some of the ARDS2 trials and kind of retroactively split those into subgroups around PDEF and 150, you don't see any differences by only teasing out the moderately to severe population. So is oxygenation a valid subgroup? And I would argue a subphenotype, and I would argue maybe not, particularly, again, early. If you have a Berlin severe within 24 hours, no longer meeting criteria after 24 hours, it's a very fungible parameter, which also, of course, is a function of mean airway pressure and recruitability and PEEP and so forth. So I'm a little, among the heterogeneities I'm willing to commit to, this is not one I'm actually willing to commit to. So when you think about ARDS trials of moderate to below severe. The only positive one was Perseva, which they had ARDS less than 36 hours, more than 12, PDEF 1 for 150 with PEEP of 5. But the ART trial tried to look at PDEF under 200. That was actually harmful. Rose, interferon 1, beta 1A, all these things trying to enrich by PDEF ratio were unsuccessful. So I think there's, to call this a valid form of heterogeneity, I think is probably not going to get you there. So let's talk about inflammatory subphenotypes. This is the thing that's been really, I think, certainly impressed NHLBI, leading to the APS consortium. This is the work of Preetak Sinha and Kellen Coffey. When Sinha was out in San Francisco, now he's in St. Louis. But what they did was they had a bunch of stuff in the freezer from the old ARDS studies, in this case, ARMA, the original 6 versus 12, if you will, and alveoli, which was the high PEEP trial. And they went back and looked at a whole array of biomarkers that were in the freezer and found that higher plasma IL-6, IL-8, TNF receptor 1, and PI1 had seemed to tease out a more inflammatory phenotype. We're more likely to be on vasopressors, have a lower systolic blood pressure, bicarbonate, and protein C. Kind of sounds like the septic population, frankly. But there was also a cohort that didn't seem to have these things, and certainly the inflammatory phenotype seemed to be more sicker. And so there seems to be, and this is getting some play here, heterogeneity of inflammatory phenotype. And when they looked at the biospecimens, not just at time 0, but at 3 days, these differences in hyperinflammatory versus hypoinflammatory subphenotype seem to persist. We don't have a prospective study, but here is a retrofit of a statin study that was a negative trial. But when you superimpose based on the frozen biospecimens, hyper versus hyperinflammatory subphenotypes, you did see a difference in this trial. Again, it's post hoc analysis, which one always needs to take with some trepidation, but it does seem to afford an opportunity for enrichment by subphenotyping at time 0. More on that later with the iSpy network. There's other ways to look at this too. You could look at, this was as a trauma population, S-RAGE and ANG2, same investigators, McAuliffe and Matt, they were on that, as well as Lorraine Ware. But phenotyping at time 0, and let's say more on this towards the end, may afford an opportunity to have some positive trials for a change. So let's talk about heterogeneity of a different sort, and that is gas exchange. In ARDS, you have compressive atelectasis, dependent lung zones. How do you know? You flip somebody prone, and the anterior lung zones get collapsed, and the ventilation's posteriorly. And this also is a function of collapse, but an area that's recruitable, that has opening and closing on a breath-by-breath basis. So instead of compressive, we call it cyclic atelectasis, potentially recruitable with PEEP. So that led after the 6 versus 12, if you will, ARMA trial, say let's give these ARDS patients a bunch of PEEP and see if it makes a difference. In alveoli, it didn't. In Loves in Canada and Express in Europe, published in 2008, it didn't. Meta-analysis in 2010 barely showed a difference. If you look at the old definition, which is ARDS with a PDEF under 200, you barely see a little bit PEEP value from time to assisted breathing and mortality, but not exactly super impressive Kaplan-Meiers. But the whole idea here is, geez, does high PEEP help? And the latest wrinkle in this came out, 6 years ago now, where people said, well, you guys didn't do it right. We're really going to recruit the heck out along with these very aggressive recruitment breaths, and actually had a lot of early deaths in codes and barotrauma, and had an increased mortality, really opening the lung with a decremental PEEP recruitment approach. I know that sounds a little fancy. I don't have time to explain it to you, because my real message to you is a one-size-fits-all approach to PEEP and recruitability of the lung is invalid. Recruitability varies. We've known this for a long time now. This is Gattinoni's work, who's got a CAT scan next to his ICU with the Schoding and Dixon. We're going to have one in the ICU. But the point of the matter is, a one-size-fits-all approach to PEEP is probably not valid, because there's heterogeneity with regard to recruitment of the lung with PEEP. And so here's some of the things he found out, that actually pneumonia is more recruitable than sepsis in terms of recruited PEEP. And if you went back in time to 2 of those trials that were in that meta-analysis, this would be Loves and Express, the Canadian and the European trial. PEEP patients who really improved their PDEF ratio as a function of PEEP did seem to have mortality difference. So if you can help people with PEEP when it helps them, when they're recruitable, and maybe not so much if it does not. The more recent wrinkle to this is driving pressure, and you can say that driving pressure, which is plateau minus PEEP, is a surrogate for recruitability. And again, you go back to some of the old trials, in this case, the European trial Express, the ARDS trial alveoli, and even better than P-DEF ratio is showing that the change in delta P, the change in driving pressure, we sometimes say call driving pressure delta P, so delta P, the change in driving pressure associated when you give more PEEP. If driving pressure diminishes, oxygenation improves, mortality gets better. So let's talk about a different form of heterogeneity, which is linked, and that is rankinographic heterogeneity. This is critical care some years ago now, talking about a focal morphology to the lung on imaging versus non-focal, and showing recruitability being more able to be achieved in patients who have a non-focal morphology. So there's heterogeneity of rankinographic presentation. This is two sides of the same coin when it comes to PEEP recruitment in a certain sense. But that led to a trial called LIVE in 2019. This was the first real attempt to, we don't have a phenotyping on inflammatory or anything like that, but a first attempt to prospectively do something different to people based on subgroup analysis. In this case, focal versus non-focal morphology to CT or chest X-ray. The control group just got good old-fashioned lung protective ventilation. The personalized group, focal, had a little more generous tidal volumes than the non-focal morphology, and they did not find a difference, sorry to say. However, your good old-fashioned post hoc analysis said, oh God, you misclassified a bunch. If you classify them, let me back up here. If you reclassify them based on what you really thought they had, it seemed to have mortality difference in the more personalized group. So maybe the issue is better imaging or better understanding of gas distribution in terms of recruitability. Maybe affords an opportunity for subgroup subphenotyping and treating people different. Maybe recruitability based on driving pressure does. We don't have the answers for it. So in terms of heterogeneity, can we design better trials? Well, you can talk about our ARDS, direct injury versus non-direct injury. This is something that's been going on for a long time, but never really studied in terms of prospective study, but there is some recruitability issues that's getting shown by CAT scan. Certainly, you talk about recruiting only patients with DAD. The problem is you're never going to know who's got it because you're not going to biopsy them and they're not going to autopsy them. Duration, persistent ARDS, I think that is important, because if you're better in 24 hours, that's good for the patient, bad for the study. If severe oxygenation, I'm skeptical of this one for reasons stated. Immune subphenotype, that may have legs, and recruitability based on delta P or focusing. So if we think about it, let's cross some of these off the list from the get-go. Let's say that focal versus non-focal recruitability are kind of two sides of the same coin. Duration kind of linked to subphenotyping, and presentation maybe like the histopathology, but really does not afford an opportunity for trial subphenotyping and differential treatment, because we don't get autopsies and we don't get VATs, certainly don't get VATs, and we certainly don't get those early in the course of someone's clinical course. Now, one other thing to think about here is what I like to call enrollment drift. And I commented to you already in terms of autopsy, in terms of biopsy, that the thing we see often enough when we don't see DAD is pneumonia. And the thing that we see even when we see DAD clinically was pneumonia. And if you look at what we're studying when we study ARDS, we're studying septic pneumonia, frankly. If we go back to ARMA in 2000, we see that only 33 to 36% of patients had pneumonia as their risk factor for ARDS. You can see the display here from the other stuff. But over time, this has gone up to usually well over 50%. This is ROSE, 58-ish%. LungSafe, which is observational, 59%. The ART trial, which was that high PEEP study with the recruitment breast, 55%. I didn't include every last study, but it's true across the board. So, and here is DEXA ARDS study, 50+%. So what do we study when we study ARDS? Well, we're studying pneumonia, septic pneumonia, frankly. I mean, more likely than not, over 50% of the time. And that's not irrelevant either to the treatments we do, and knowing that what's in the lungs is not necessarily DAD anyway. So no wonder we've got negative trials. So enrichment opportunities include inflammatory phenotype, recruitability, and then CAP versus other etiologies, I suppose. Maybe if we just embrace the notion of CAP and treat those patients differently. Now, it's already being done to try to look at enrichment. This is a company called Randox, and they're testing IL-6 and soluble TNF receptor 1, which were two of the more potent, if you will, and discriminant variables for Coffey and Sinha's hyperinflammatory phenotype. I-SPY was a COVID network. Actually, I-SPY was a breast cancer network out of UCSF that evolved during our COVID pandemic into a COVID trials network, which is now kind of evolving into a ARDS network if possible. They're probably going to link up when UCSF gets the DoD grant, which they're likely to get. And the idea here is let's go right to the bedside and stratify people at time 0, and let's have our interventions treat this hyperinflammatory phenotype because we're taking it right to the bedside. Another way in terms of enrichment that's being acted on is delta delta P, driving pressure. Serena Saheta is from Hopkins, not Canada, but had, like me, gone against the pedal network process for getting our trials done and never got her driving pressure trial done. There's a group forming out of Canada calling themselves Practical. This is Eddie Fan, Neil Ferguson, and Ewan Gallagher, and they formed in the fall. And we've been invited to participate. I'll be at an investigator meeting at ATS on Sunday, and it's driving pressure. So Serena, I congratulate her. Congratulations on getting your trial finally done. And the idea again is to treat patients differently based on recruitability, based on response to PEEP and determining driving pressure, delta delta P. So this is a new wrinkle that affords an opportunity as well. Last thing I'll point out is, I've been playing with electrical impedance tomography. Victor Jimenez did a wonderful job. He's over at Yale now. And we did have a paper in critical care, which looked at titrating PEEP by where the lines cross here, the greatest crossing point between recruitability and overextension to find that sweet spot. But actually, in my interactions with Serena, she put me in touch with Marcelo Amato, who's a big EIT guy. And Marcelo is from Brazil, was involved in the ART trial, for example. And we are hopefully going to phenotype, if you will, based on gas distribution according to EIT, with an eye towards perhaps repeating that live trial to treat people differently based on gas distribution based on EIT. And to that extent, respiratory therapy group, Mark Conkle, Andy Wyrick, and with a financial contribution from leftover trust money for me, we're trying to get an Enlight EIT to participate in that work with him. So the last kind of heterogeneity I wish to mention is corticosteroids. I told you I'd go there, and I can't resist. Everyone loves steroids, maybe not as much as me. But I say heterogeneity, and the reason I say heterogeneity is because influenza. You might recall 3 years ago, we did not give steroids to patients with COVID-19 initially. And the reason we didn't was H1N1. And this is some analysis data. It's mainly observational, but the point of the matter is it seemed to be a consistent signal that particularly early, within 3 days of presentation, severe influenza patients developing ARDS actually did worse, had a higher mortality when given corticosteroids. And we extrapolated, as one often does heuristically, from the known to the unknown, which in this case was COVID-19, where we thought, all bets are off. And we didn't give steroids until recovery trial and other trials demonstrated efficacy. So clearly there seems to be heterogeneity. The point being, we were afraid to immunosuppressive steroids while patients were actively replicating virus, and that's going to be bad for them. Turns out that's not true. Now, the DEXA ARDS trial was pre-COVID, and actually kind of got lost in the sauce because it was published in January 2020, and of course, 2 months later, COVID hit, and I'm not sure necessarily the awareness of this article has been as significant as perhaps it could have been. The largest trial we had, you might recall the biggest trial previously was our Lazarus ARDS-1 trial of 180 patients. So we have not quite double, but more patients enrolled with a clear benefit towards corticosteroids. And of course, I've already mentioned to you what we tend to study with ARDS, and the big confounds here are CAP and sepsis. Now, certainly cortisone seems to be important in the mix when you give steroids to sepsis, no argument, but these other conditions, which exhibit the same high degree of overlap with ARDS, again, we tend to be studying septic cap patients and putting those in our trials preferentially, also seem to benefit from corticosteroids, which leads me to the Great Lakes Clinical Center. And I was very happy that I was able to postpone this talk sufficiently until we finally did find out for sure, as we did a week and a half ago, that we did receive the award that Prescott, Dixon, and Hyzy are co-PIs on, and several of our other colleagues here. We had a nice beer fest last week at Holmes campus, but you can see where this lecture has brought us, and that is to say the great confusion of that syndrome of ARDS, the great heterogeneity, the great confound of pneumonia and sepsis, which are the other things that are going to be phenotyped in this consortium. And that's why this work's important, I think, because clearly the frustration of all these negative trials was not lost on NHLBI. And so instead of the tactive pedal of let's enroll ER patients didn't work, was misguided perhaps, taking a pause from intervention, taking a step back and saying, let's try to figure out a little bit better what we're doing and then design trials accordingly. So we're very privileged to be part of this group. And like you said, we just, it's supposedly a May 1 startup date. So I don't think that's, we're going to be enrolling anybody by May 1, but hope is maybe fourth quarter of this year, we'll have things settled as to what exactly we're going to do to take a look at these people. So heterogeneity in ARDS, I hope I've convinced you rather, is redundant. It's a syndrome marked by an array of aspects which are not uniform in nature, i.e. heterogeneous. And you can look at it in multiple different ways, as I have attempted to demonstrate to you. And besides Arma, Procevidex, ARDS, and if you will, Eolia, our trials have been negative. So we got a problem. I mean, if you're satisfied with 30% mortality, we don't have a problem. But if you think we can do better, then we've got a problem. And there's been enrollment drift. That's my cute term. I can't see, no one's as excited about that as me. But we're enrolling patients with CAP, mainly septic CAP patients who have risk factors for persistent ARDS, who are worthy of study, who all respond to steroids. So it gets pretty confusing. And future studies need to address the heterogeneity up front instead of just worrying about HTE in the rearview mirror. By subphenotyping various ways, I've suggested to you some of the ways investigators now and in the future are hoping to address this issue, to maybe figure out how to help patients on a selective basis according to the subphenotypes we've identified.